The information that I'm going to disseminate tonight will likely pertain to at least 1 out of 3 people sitting in these pews tonight. One way or another, what I'm going to disclose will help you prevent a stroke in the event that there is a symptom developing in your body of an acute stroke. You're going to know what to demand from your health provider, your emergency room physician, because it isn't always obvious. It isn't always obvious to the doctor, and doctors don't always make the best attempt to reverse what can be a crippling stroke, where you remain in a nursing home for a decade or longer with half of your body paralyzed when effective interventions could have been implemented. And I want to say 3 years ago, almost 3 years ago to this day, my aunt suffered an ischemic stroke. It was reversible had the information I'm going to disseminate tonight been used, but she didn't go to the right hospital. They didn't have the technology, and as a result, half of her body has been paralyzed. She's been in a nursing home for the past 3 years. All of that was unnecessary, and it's because of her stroke that motivated me to look into why couldn't they remove that blood clot that was occluding flow to a portion of her brain. And it turned out there was a way. She just unfortunately was unable to get to the proper medical facility. Now, there are about 2,000 acute strokes every single day in this country. If you add that up, it's over 700,000 a year. So this is not an insignificant problem. It's a major health issue. It's often listed as the 3rd leading cause of death and the #1 cause of disability. And these disabilities are horrific. Paralysis, which includes losing hearing, losing your vision on one side of your body. It's a horrific procedure, and you're in a place where you don't want to be. You're around a bunch of other people who are suffering from Alzheimer's and other fatal conditions that take a long time before the lethality manifests. So this is not an insignificant issue we're talking about. And as it relates to what are the outcomes? Well, if you go to the right medical center and they implement the right procedure, you may be out in a few days. Even if it was a major stroke, they now have technology to reverse that acute ischemic event. Ischemia refers to loss of blood flow. And as it relates to ischemic stroke, that's loss of blood flow to a portion of the brain. If there's enough loss of blood flow, by the way, the stroke can acutely kill. But in many cases, it leaves the victim paralyzed. In some cases, there's a recovery. In many cases, it's permanent paralysis. The patient never leaves the nursing home confinement. Now, what we want to talk about first is what's the best way to prevent the occurrence of a stroke in your body. And it is keeping your blood pressure at the low end of the normal range. Don't think about normal from the standpoint of the way the American Heart Association defines it. You want to be in the optimal range of blood pressure, which the American Heart Association just 2 days ago made a major announcement that confirms what our organizations have been recommending now since the mid-1980s. The American Heart Association now says optimal systolic blood pressure readings are under 120 millimeters per mercury. That is huge. That's a huge breakthrough from the standpoint of conventional medicine catching up on where optimal blood pressure should be. Now, so many people, when they're diagnosed with hypertension, they interestingly say, well, I've always had low blood pressure. This is what they'll say to their doctors and their friends. I've always had a low blood pressure, and here I've been diagnosed with hypertension. Well, the fact of the matter is, hypertension is a manifestation of normal aging. And as you can see from this chart, the vast majority of people who are over 65, over 75, the vast majority are hypertensive. And this is based on the guidelines before the American Heart Association made the announcement 2 days ago that optimal readings are under 140. This chart is based on readings that are over 139.
In other words, they were looking at people's systolic pressure, and that's the most important one to realize, by the way, that upper number, the systolic number, because that reflects the pumping of the heart and the pressure against the arterial system with each heartbeat. And as you can see, lots and lots of people have hypertension. The reality is the vast majority of Americans over age 65 are now clinically hypertensive as it relates to the conventional guidelines. Now, we look at the diseases that are related to hypertension, and it goes way beyond stroke. People can have their kidneys shut down and be on dialysis. That's a thrice weekly procedure where you go in and they'll run your blood through a dialysis machine. It only partially cleans it the way your healthy kidneys were, but it's an inconvenient thing to do, and it has its own set of side effects. And what that means is you can be undergoing dialysis, your homocysteine levels go through the roof, your C-reactive protein levels go through the roof, and you are at a significantly increased risk of cardiovascular disease by virtue of the dialysis procedure itself. But it's needed if your kidneys happen to shut down. But in response to hypertension, there's some mild cognitive impairment. Your coronary artery disease risk surges. You've got all kinds of risk factors that could all be prevented if you just kept your blood pressure into the optimal range, which is under 120 on the systolic number. You want that to be under 120. I try to keep mine under 115. People who practice calorie restriction, their systolic blood pressure is often in the 90s. It's very low, and they're very healthy. So it just gives you an indicator that normal blood pressure for a typical person, it's going to be around 150 systolic. Well, they normally will then suffer heart attack, strokes, kidney failure. They'll have all these other problems because they allowed what the conventional medicine said was normal to apply to them. We want to be abnormal. We don't want to be like everybody else who suffers all of these degenerative conditions of aging. And that's why we're fighting so hard against the establishments continuing not to recognize what optimal blood pressure should be for most of their patients. Now, there was a huge debate that's gone on for over 30 years as to what the definition of hypertension was. And they used that word abnormally high blood pressure. But in reality, that's not really the case. Medicine would define blood pressure as any level high enough that it may eventually cause a disease to manifest. And what we looked at, though, is the fact that, well, most people have higher than optimal blood pressure. Hypertension is not abnormal by any means. It's abnormal if you're 65 and older to have blood pressure at the low end. You can push it down, by the way, with lifestyle changes and medications, but if you're 65 and you don't have hypertension, you're abnormal. So you want to get yourself into a situation where you have optimal blood pressure readings. And all of this data, by the way, that I'm presenting tonight was before the American Heart Association made their announcement that they finally agreed with what the scientific literature consistently showed. And that is people with low blood pressure live longer, have fewer strokes, fewer heart attacks, fewer incidences of all the diseases related to hypertension. The doctors got it wrong for well over 30 years. They were allowing people to leave their office with a systolic reading of 140, 150, and the doctor said, yeah, this is normal. This is what we're used to seeing, so you're okay. But of course, these people were not okay. That had horrific consequences. So this was a debate. Conventional medicine for decades said 140 over 90 is when you begin considering treating high blood pressure. Founders of this church, we said, well, wait a minute. If you're 140 over 90, you're at a significantly increased risk of all of these diseases, and yet the doctors weren't treating it. So we said, keep it under 120 over 80. Our optimal reading that we've said for many, many decades is 115 over 75. That's a target to shoot for. Doesn't mean, by the way, you should do it all at once. Older people, if they try to drop their blood pressure too fast, they can suffer some issues related to hypoperfusion of their brain, which could cause them to have a fall. So if you do have high blood pressure and you realize you need to lower it, it has to be done over a multi-month period. It has to be done very slowly, and you want to take some blood tests to ensure that your kidneys are not being adversely impacted. And I say that from the context that when a person has, let's say, a systolic reading of 150 and they panic and they push it down to 115, the kidneys, well, they're used to having that strong flow of blood running through, and they sometimes then fail to filter out the toxins from your blood. So if you are hypertensive and you're older, slowly reduce your blood pressure and make sure you have an at-home blood pressure monitor so you can see what results you're getting with changes in lifestyle and or medications to slowly get it from, let's say, 145, 150 to get it down below that 120 number, as long as you don't have symptoms of fainting, symptoms of dizziness, symptoms in which a blood test results in showing some kidney impairment. So if you look at the deadly impact of systolic blood pressure in the readings in which conventional medicine used to accept, a 71% increased risk of stroke if your blood pressure is between 120 and 139. I mean, that's huge. 50% increased risk of coronary artery disease. These are huge increases over one risk factor. Just one risk factor results in these huge increases, and doctors up until a couple days ago said between 120 and 139, that's okay. And we said it wasn't, and we were right, and we've saved a lot of lives, but not nearly as many as we could have. So this was the debate. It went on and on. I used to go on TV shows, radio shows, and talk about this, and medical doctors would call me in and say, I don't treat my blood pressure patients until it reaches 160 because they're all hypertensive. And I couldn't disagree with them. They were all hypertensive, but you should have done something to lower it, because the fact of the matter is the data revealed something else. And these benefits were conferred in year 2015. And this is the study that the American Heart Association based their recommendation 2 days ago on lowering blood pressure below 120. Because as you can see, there's a significant reduction in heart attack risk and stroke and overall mortality. 27% lower risk of dying if you keep your blood pressure below 120 as opposed to targeting it below 140. These are data, of course, published in the most prestigious medical journals in the world. These are supposedly read by medical doctors, but if they do read it, they fail to incorporate it into their medical practice. This is a real unfortunate event. So, according to the American Heart Association's new guidelines, November 13th, the term prehypertension no longer exists. They have abolished the use of the term prehypertension, which was previously used to define blood pressure between 120 and 139. And the reason they abolished that is that slide I showed you a couple times ago. You can see that people who have blood pressure between 120 and 139, they're not in very good shape. But if they push it below 120, they get all of these benefits. These are significant benefits, and these are ones you got to remember. If you sometimes lapse when it relates to blood pressure and you have an at-home device and you're seeing yourself consistently at 135, well, you're going to say, I need to do something about that because I want to reduce my risk of all these disorders simply by pushing it below 120. So we have that huge amount of data that substantiates what we have been preaching at this church and at other events for a very long period of time. We've been presenting this data in a way that I'd like to think people have paid attention to it, at least the people who I've been working with. As it relates to the other risk factors for stroke, because blood pressure probably is number one right now. That is the number one way you can reduce your risk of having an ischemic stroke and even a hemorrhagic stroke where a blood vessel in your brain will rupture and bleed. I mean, that's a terrible thing, and that's even harder to treat. But nonetheless, these are the blood factors that are involved in ischemic stroke and coronary artery disease and renal impairment. A whole host of vascular-related ailments relate to high levels of C-reactive protein, homocysteine, fibrinogen, LDL cholesterol, and of course glucose and insulin. If these levels in your blood are elevated, well, take some steps to lower them. By doing so, you lower your risk of a heart attack and a stroke and a host of other vascular-related situations. These situations, by the way, in some cases are very easy to reduce, as is blood pressure. There's a medication that we've recommended for several years called telmisartan. We think it's the best antihypertensive drug available, and here it is. It's a generic, doesn't cost a lot of money, and people don't even ask their doctor for the best drug. Sometimes the doctor prescribes a less than optimal drug. What I'm going to talk about now is what to do if you have symptoms of an acute stroke. What do you do to remove the clot that's impeding blood flow through a critical artery in your brain? Very, very important. You need to do something about that blood clot. Well, unfortunately, up until very recently, the doctors were giving up too soon. Patients would come in with a blocked cerebral artery, and they weren't aggressively treating it. They'd literally watch the patient slowly become paralyzed and give them a little bit of heparin maybe to keep it from getting worse, but they do nothing to dissolve the blood clot. And what caught our attention was a study back in 2011, and it showed that there was an effective therapy that had been approved, by the way, in 1996 called tissue plasminogen activator. It's a drug that, when administered systemically into a patient, will dissolve many of the clots that are blocking a portion of blood flow to the brain. It's a clot dissolving drug. And yet, all these years after it was approved by the FDA in 1996, only a small percentage of community hospitals were using this drug. And this is an indication where if you don't know to tell your ER doctor, use TPA, tissue plasminogen activator, on my mother or on my loved one, whoever the person is that you're the patient advocate for, there's a strong chance that the doctor won't utilize the best therapy. For all kinds of reasons, medical technology that's in the published literature does not translate into clinical practice as quickly as we'd like. And as a result, you've got millions of people needlessly suffering paralysis and death, needlessly suffering that. So again, the clot that blocks blood flow to the brain is what's the underlying factor that creates paralysis and death. You want to get rid of that clot. And the technology was developed around 2006, where they would thread a catheter into the cerebral artery and mechanically remove the clot that was occluding blood flow to that portion of the brain. This is called an endovascular thrombectomy. It's a good word to put in your iPhone or something, because in the event you're in an ER room, the doctor may not recommend an endovascular thrombectomy, even though it may very well save your life. The good news is more and more hospitals are incorporating this, but when I first started putting on these presentations, there were very few. There were typically one hospital in any given area that had the ability to deliver this therapy. What they'll usually do, by the way, first is try to use the TPA clot-dissolving drug. And if that doesn't work, they'll go in there with a thrombectomy and attempt to remove the entire clot, or do a combination of both. Maybe the TPA will be put right under the clot, and then if not dissolved, mechanically remove it. So an important word, endovascular thrombectomy. Thrombo stands for thrombus, blood clot, and this is the removal of a blood clot in the vascular system. Now this is a picture of my father-in-law holding his 6-month-old grandson. He was otherwise a healthy 80-year-old individual, but he had very incompetent medical care. He was undertreated for hypertension. He was given old-line medications that were not controlling his blood pressure very well, and just a few months after this picture was taken, he suffered an ischemic stroke, and he remained paralyzed for a number of years. And here he is in a nursing home bed. That little kid he was holding is now about 3 years old. He had a second grandson, didn't get quite able to enjoy that grandfather experience, laying there in his own waste, unfortunately not able to get out of that bed. Half his body was paralyzed. He suffered a miserable 3 to 4 years before he died. Had he been given proper treatment for hypertension, he never would have had the stroke. Or if he had been given proper treatment for whatever blood factors may have been underlying it, he wouldn't have had that stroke. So he is a victim, as is my aunt, as are many people you know. Many people you've known have suffered strokes. And up until the last couple decades, there wasn't a whole lot that could be done about it. And yet the scientific literature indicated that people who kept their blood pressure low, kept their LDL levels and glucose levels at the lower end of the normal range, well, they weren't suffering these horrific consequences. And that's really unfortunate that something's published in a medical journal and it can take many decades before the public takes advantage of it. This is an article that I wrote in 2015. I sent a draft of it around in 2014 to let people know about the endovascular thrombectomies. Here it was a technology that was available, but it was being underutilized, and people were being paralyzed from stroke that could be reversed on an acute basis. And that's one of the titles of this talk, is Reversing Acute Ischemic Stroke. Once the brain damage has occurred, well, then we're going to have to utilize some of our age reversal technologies to try to restore neuronal function. Because once those neurons have died, there still are ones that are injured that we might be able to rescue. But it's too late. This is an incidence where when a person has a stroke, there is a relatively narrow window as to when that stroke can be reversed. Now, you look at this New England Journal of Medicine editorial, January 1st, 2015, and they talk about the thrombectomy being effective up to 6 hours after the onset of stroke symptoms. And they were advocating that it become more widely used because they had already had about 9 years of experience showing that this therapy was effective in reversing stroke. And then what happened just this year, May 2017, some doctors got to be real aggressive with these thrombectomies, and they were finding that up to 24 hours after the onset of an ischemic stroke, they were able to recover the patients. They were able to reverse the impact of that blood clot that was lodged in the brain that was slowly killing brain cells. Now, this is a huge advance in medicine. And how it pertains to the knowledge base that you now have is, you may have a relative, a friend, or yourself. You're in an ER room, and a doctor's saying, oh, well, it's more than 6 hours. We can't use the thrombectomy procedure. Well, you know right now to say, guess what, doctor, maybe you missed this. It's effective up to 24 hours after stroke onset. And the reason it's effective is, for some people, they have collateral circulation in the brain. And even though a huge percentage of blood is blocked by one clot, they're still getting enough blood flow to keep those brain cells surviving. So that when that blood clot is removed with a thrombectomy device, a percentage of them are going to be able to survive. So this was the data that came out in May of 2017. And I doubt a lot of doctors right now understand how much more effective a thrombectomy can be even after that 6-hour window. Because I don't think this is approved by the FDA, by the way, after 6 hours. That doesn't stop the ER doctor from having the procedure done. You don't need FDA approval to implement a procedure. You need FDA approval to promote a procedure. I am promoting this procedure because I don't sell it, so I'm allowed to do it. Unfortunately, those who have developed the technology and advanced it, they have to wait for the FDA's rubber stamp of approval. But you know different. So in the event of an ischemic stroke, don't give up until at least 24 hours, because we now have hard data that we can revive people from acute ischemic stroke a lot longer than what they used to think the upper limit threshold was. So there are a number of South Florida medical centers that are providing the endothelial removal. If you look at the timeline here, when 2014 rolled around, we called around all the local hospitals, all the way from South Miami up to North Palm Beach, and most of them were not considered comprehensive stroke centers. But we did identify one or two in each county that did have the technology. So we move forward to year 2017, and the good news is, well, most of the hospitals now have incorporated this technology into the emergency room setting. What they typically do is they call a neurosurgeon in or a vascular interventionalist to do the endovascular thrombectomy so that they're all able to pretty much offer this. So this slide presentation will be available online, by the way, and we had some good news when we called around all the hospitals in year 2017, like we did in 2014. We found out that most of them were offering this therapy. So when you go on the Church of Perpetual Life website, you'll you'll get to see the fact that most of the hospitals now offer a procedure 3 years after 2014. This is Dade County. This is information that you really should log on to the Church of Perpetual Life website and identify what is the closest comprehensive stroke center to where you live and or work. Because you want to make sure when that ambulance comes, they take you to where the technology is, not to where the closest emergency room happens to be that may not offer this type of technology. This is invaluable information. It means the difference of walking out of that hospital in a day or two or being taken by ambulance to a nursing home where you'll spend the rest of your life. And again, Palm Beach County, there was only 1 or 2 back in 2014, and now it seems like they're all incorporating this novel way to reverse acute ischemic stroke. But I have to emphasize again, you need to know to demand it, because the ER doctor might feel you're not a candidate for it. Well, if you know you're being paralyzed, you can feel it happening, you might say, well, then just take a chance and try it anyway, because after 24 hours or within 24 hours, it very well may be effective. So the endovascular thrombectomy, which we passionately advocated for back in 2014, it's now becoming standard of care, but not quite there yet to guarantee you're going to get the best treatment. I mean, if you go into an ER room with a coronary artery blockage, well, they're real good at reversing that. They've got ways of putting in stents, using TPA, doing emergency open heart surgery if they need to. So they're good with the coronary artery occlusions, but they're not 100% covering the cerebral vascular problems. So what we have here is a rapidly changing window of time, where if we go back to 1995 and you had a stroke, nothing really could be done of substance. And then the TPA drug was approved, and that was recovering some people. It was a good drug, but it wasn't used enough. And we move forward again with the thrombectomy, and lots more people are being recovered. So as it relates to when a person is dead, well, before, let's say in 2017 even, lots of stroke victims were going into hospitals, being declared dead and taken to mortuaries. And yet an endovascular thrombectomy could have saved their life. What we contend, by the way, is that there are equally effective technologies available right now, but they're being underutilized, so people are needlessly dying. Now, these are the age reversal projects that we are currently investigating. I'm going to try to update you on each and every one of them, if I can right now. Repairing cellular DNA with NAD+ infusions. Those are going to be available in South Florida, I'm hoping by December. We're just asking as many doctors as we can to look at the literature and incorporate that in their infusion practice. These are doctors who do vitamin infusions, glutathione infusions. We're asking them to consider the NAD protocols that are being developed. And the good news is the dose of NAD we're finding can be cut in half, and the number of infusions may be reduced from 6 down to 3. So that means just 3 days of being infused for about 3 to 4 hours. You bring your laptop computer in, or your iPhone, or a newspaper, whatever, while they're infusing you, and then you leave. And in doing so, you are going to facilitate DNA repair. You may lengthen your telomeres. You're going to strengthen your stem cells' ability to function. Huge advantages to NAD+ infusions. And as soon as we have a list of the doctors, we're going to post them right up here, and you can call them up, make your own appointments. I'm sure they'll be charging different prices. You make your own choice as to what doctor is most convenient and most affordable to you. The systemic regeneration using young plasma. Many people are experimenting with different types of young plasma in an attempt to reverse biological aging on a systemic basis, a systemic reversal. Dr. Maharaj's study has received FDA approval. A number of other people are using different techniques, indicating that individuals who have been putting cord plasma into their bodies are getting some rather spectacular reversals on aging biomarkers. One of the most common biomarkers that we use is to evaluate DNA methylation. And as we grow older, our DNA methylation, it declines. One individual who had undergone 4 to 5 cord plasma infusions was able to see a 12-year reversal in the measurement of DNA methylation. Pretty significant. The thymic regeneration, they are working to refine that and make that available. That utilizes growth hormone and some other drugs for only 1 year to regenerate the thymus gland and reverse immune senescence. The GDF-11 project with Steve Perry up in New York, he is inundated with people who are now self-experimenting with GDF-11. He's meticulously tracking that data, so I continue to hear good reports about that. The dasatinib quercetin study to remove senescent cells. That study has concluded. We now have preliminary data on humans who are given high-dose dasatinib and quercetin for 1 day, just one administration, and the preliminary results, these are only anecdotal, we'll have final results in about 3 months. 50% of the osteoarthritis people are reporting partial or complete remission. And we will follow these people up to see if more of them either go into remission or maybe it was just an anecdotal feedback that was premature. But what we did to avoid the placebo effect is we did a baseline MRI of their affected arthritic joint, and we're doing follow-up MRIs. So we will know if the senolytic therapy using dasatinib and quercetin was able to reverse aging, at least in their joint, and hopefully systemically, because some of these people are reporting actually feeling much younger. And for those who don't understand this concept, when we grow older, we have an accumulation of senile cells that interfere with cell-to-cell communication. They kind of gum up the works in our body. And those senile cells emit inflammatory factors. So it generates chronic inflammation and impedes cell-to-cell communication. By removing the senescent cells using a leukemia drug, dasatinib, just so you know what that drug is used for. Leukemia patients take it almost every day. We're talking about 1 high dose of dasatinib and quercetin to remove as many senile cells as we can and observe what kind of age reversal effects are occurring. That study is complete. It was done on a low budget, so we were able to do it quickly, and we do have preliminary results. We'll have final results that we'll report on at this church. As it relates to the cellular debris that accumulates with aging inside our cells, there is a drug that organ transplant patients use every day called rapamycin. And that drug has a number of benefits, but one of them is to rid our cells of the accumulated toxic waste products that clog up their efficient operation. The rapamycin study is going to start very shortly in Southern California. And again, we're going to be looking at a wide range of clinical measures and biomarkers of aging to see if we cannot observe an age reversal effect using an existing drug, a drug that's already used by lots and lots of people, but using it in a creative way, which is about 5 milligrams of rapamycin once a week. Some people are using between 2 and 6, so that's the range between 2 and 6. But instead of using it every day, which would be toxic, once a week does not appear to be inducing toxicity. Mesenchymal stem cells, several people are going to be pursuing research projects aimed at using mesenchymal stem cells to regenerate older people. And then the hematopoietic stem cells for autoimmunity and cancer, those studies are also proceeding. So lots and lots of good technology happening right now, and I'm getting updates. Every couple of days I get a little update, a little anecdote, or I get a clinical measure. The clinical measures are a heck of a lot better. And my own personal experience, by the way, with the NAD plus infusions, I've talked about that before, my sleep patterns are about 80% better. That's the reason I underwent the NAD, because an accidental finding in our NAD infusion research is that everyone who underwent it, and they were typically 80 years of age and older, they were all saying, I'm sleeping a lot better. And they were just volunteering that to us. We weren't asking them that question. So when I heard about something that lets people sleep better, I said, well, I'm going to undergo these NAD plus infusions. And as another benefit that's a direct clinical measure, my systolic blood pressure readings are about 15 points lower. I don't take telmisartan anymore, by the way. I was taking it to keep my blood pressure nice and low, but after the NAD infusions, I don't need that antihypertensive drug. So those are two specific benefits I personally received after undergoing NAD infusion therapy in April of 2017. I was impressed enough to try to encourage as many doctors as I can to offer this to their patients so we can reverse as many aspects of aging as possible to stay alive until even more fantastic developments occur. This is a chart we've shown before about the multiple benefits of NAD. And what stimulated me a lot, just last night I read a brand new paper. It deals with restoring our own stem cell function. And stem cells are kind of a buzzword. People use them sometimes inappropriately, and some people go and have stem cells put into their body in a way that's dangerous. It would be better to turn back on your own stem cells. And NAD and also boosting AMPK, which is what a lot of you are doing right now with metformin. If we boost AMPK and boost our NAD levels, we seem to restore functionality to our existing stem cells. We reactivate them. So this is a huge, huge opportunity for us to use existing technologies to benefit ourselves. So again, lots of benefits to restoring NAD+ levels. When we were born, we had high levels. When we were younger, we had high levels. By the time we reach age 50, those levels are cut in half. And by the time we hit 80, we've got about anywhere between 1 and 10% of what our youthful NAD levels were. The infusions boost them, and there are ways to keep them boosted through NAD precursors. This was a study I ran across recently, published about the senolytic drugs. As I mentioned, the dasatinib quercetin study has concluded, and these people are talking about the fact that the drugs are working so well in the animal model, it's time to do the research in humans. Well, we already did it. We already did it. These are Mayo Clinic people, and it takes them forever to do clinical research. They don't seem to have the sense of urgency that people in this church do. We are rather desperate. We're aging rapidly, and if we don't do something about it, these breakthroughs may benefit our children. They're not going to benefit us. So the ultimate goal is to develop the appropriate protocol that an aging person should undergo, and it would be based on individual variabilities. I think a person who has any kind of cancer issues should probably undergo dasatinib and rapamycin therapy first, and then follow that up with the NAD+ infusions, and then perhaps young plasma concentrates. GDF11 is in young plasma, but you can get a more consistent dose of it if you actually use the GDF11. But this is what we're working on right now to develop a systematic way to reverse biological aging in people and make it so that we can track the results and also make it individualistic enough so that we don't introduce the wrong intervention first. So the typical person might undergo NAD+ infusions first and then undergo the dasatinib and the rapamycin. Or there might be another way of doing it. But that's what the research is all about. That's what we are focused in on. So this is our game plan to accelerate human age reversal research. It involves volunteer activists, it involves donors, it involves a large constituency of people. Some people are able to self-fund their own research, which is fantastic because that enables more research dollars then to go into experimenting with people who don't have those dollars. So for some of the wealthy people who've approached us, we've suggested, well, just pay for this research. Just have yourself as an experimental subject, but not be part of the formal study. And that way you can free up monies for other people who are less fortunate. So we have a number of individuals who are literally inundated, myself and some other people I brought on board, with their desire to become self-experimenters. So I want to again urge anyone in this audience who is interested in age reversal technologies to please register on this website so we can let you know when they are available. And I have people asking me all the time, and my often response is, well, you are registered on this website, aren't you? We set it up, it costs us some money, but the idea is to be able to track people who are looking for specific interventions so we can let them know when they may be available, what doctor might make that available. So that's the website you want to pay attention to. Now, I've shown this slide on a number of occasions. It was a prophecy made by Benjamin Franklin. We at this church, of course, absolutely believe it, but I recognize the name Joseph Priestley. This is a letter he wrote to Joseph Priestley. didn't quite know who Joseph Priestley was. I had heard of him, didn't quite know who he was, so I did a quick search, and it turns out he's a rather interesting individual. He discovered oxygen, discovered soda water, advanced the science of electricity, and then he went way beyond science. He promoted equal rights for religious dissenters. Paid a big price for that, by the way. His English home and church were burned down. Back in those days, science didn't mesh well with religion. And he tried to do it, somewhat analogous to what we've done with this church, and he paid a big price. So he had to flee England before they burned him alive and come to the United States. And what's interesting is, by the time of his death, he was a member of every major scientific society. So if you want a take-home lesson, so to speak, go onto Google and type in Joseph Priestley, and you can read just page after page of incredible work that he did, and he was vilified for it. He could have very well been executed for his doctrine that religion and science belong together, and he actually felt that the Christian scriptures would be carried out by mankind advancing medical science. That's the way he viewed it. And that's very analogous to Fedorov, our prophet of this church, who viewed medical science, scientific progress, as a way that fulfills the reason we were created for. So Joseph Priestley, very interesting individual, and I really wouldn't have read about him if it wasn't for letters that he exchanged between Ben Franklin and himself. So it was a very enlightening week when I discovered that. So we have concluded my talk for tonight, and I'm open for any questions that the audience might have.